My name's Elizabeth Sue. I'm a senior pharmacist with the Medicines Optimisation Service with Austin Health in Melbourne, Victoria, a major metropolitan tertiary health service. So a particular interest area for us was opioid analgesic stewardship. So opioid medicines can be very effective for pain. The thing is though, we have to use them wisely, but also long-term use, people are at higher risk of developing things like dependence and addiction. The project that we did was looking at implementing an electronic opioid management plan in the discharge summary. So making sure patients who were leaving the hospital from ED or surgical settings with opioid prescriptions, they had a very clear plan within their discharge summary about what new opioids were started, what they were being used for, and what the plan was, so how long these medicines were meant to be used for and any plans for tapering and that. So initially we were trying to create a plan that would fit every situation in the hospital, so patients with chronic pain, patients in palliative care, or patients in acute pain. But we found that was not really quite fit for purpose because the workflows and the documentation practices within these areas are quite different. For acute pain, after surgery and in the ED, we were looking at about 11,000 patients having opioid prescriptions in those settings every year. And when the clinical care standard came out, it just showed us that actually this was an issue nationally, so not just at our hospital, and a really important thing to prioritise and to address. So we asked the clinicians, what's the important information that you're trying to relay to GPs and community prescribers for patients on opioids, and what's the cleanest and most straightforward way that we can fit that sort of documentation into your daily workflow so it doesn't become a burden and a hindrance to you, but actually helps you to provide the sort of care that you want to provide. We then worked with our electronic medical records analyst team at the hospitals, and we worked with them to build an electronic opioid management plan tool into our medical records. But what they needed from us though was very clearly exactly what are you trying to achieve, where is it going to turn up within the electronic medical record, and when do you want triggers to fill in this tool to come up. We got many different people involved, so people from junior prescribers on the ground to also some of their senior consultants as well. And we also presented that to user groups before we did the full implementation across the hospital as well, so that people on the ground could see, well, some of my seniors and peers have tried this out, they know it works, so I'm going to have some confidence implementing this into my daily practice as well. The thing about healthcare is it's constantly evolving and changing over time with new evidence and new workflows. So it's really important to have monitoring systems to be able to show us how things are working over time. We have an electronic dashboard that tracks whether our opioid management plan tool has been used, so whether it's been filled out for each patient to say what opioids are new, what is it being used for, and what's the duration and plan for those medicines, but also whether that information has been translated into the discharge summary as well, so it's getting to the GP who's going to be looking after the patient after hospital. If there is a drop in numbers, we can then delve deeper to see which prescribers or which teams within the hospital may or may not be using the tool, and then we can go and approach them and ask them, what's happening on the ground and how we can help in that way. So when we first started this work, we had some baseline studies done at our hospital looking at opioid naive patients, so patients who weren't using opioids before hospital in the surgical settings. A bit under 13% of those patients actually had the required opioid management plan information within their discharge summary. After implementing our tool though, our recent data from the end of August to December in 2024 shows that 74% of patients now have information with opioid management plans within their discharge summary. So that's a really huge jump from what we were seeing at baseline. So for ED patients, we found about 44% uptake of this opioid management plan within the discharge summaries. What's happened more recently is a workflow improvement in ED to make sure that prescriptions are written before discharge summaries are written, and now we're seeing 86% of discharge summaries within the ED have information about opioids when they have been prescribed. So it's not often within healthcare where you can go ahead and say you've managed to double your results from baseline. So these are results that we're very proud of at our health service. So being able to prove consistent results and success over time gives everyone confidence in these quality improvement initiatives, and so therefore the next time you come across an issue and you're trying to get everyone on board to work together to solve a problem, you build confidence that this is actually something that's going to be worth everyone's time and is really going to make a difference in the long term. And it's absolutely impossible for any one individual or any one team to be able to make that change. So it's really important to collaborate with everybody from different treating areas and from the leadership and from on the ground to be able to come up with solutions that are going to work. When it comes to sustaining workflows and sustaining tools, the important thing is really around the design. So if you can build your tools to slot into daily workflow and to make things as smooth and as efficient as possible for people on the ground, then they're going to take up those tools with great aplomb, and that's how you're going to be able to have success in the future.